Good afternoon, everyone. I'm Kevin Galetz, and I'm an industry education coordinator working with the Regina District Industry Education Council and the SunWest School Division. Today it's my pleasure to introduce Dr. Alistair Smith, who works as an anesthesiologist at Stratford General Hospital in Stratford, Ontario, which is located near London, Ontario. Dr. Smith is a graduate of Rosetown Central High School, and he's going to talk to us about his occupation and the career path and training he has taken to get there. Just a reminder before we begin, this session is being recorded and will appear on the RDIEC YouTube channel for you or others to view in the future. We'd also like to request that any students who watch this session go to our website at www.rdiec.ca and complete the student survey that can be found near the top of the website homepage. Completion of the survey gets your name in a monthly draw for a $50 gift card. Again, the website is www.rdiec.ca. So once again, welcome, Alistair. I'll turn it over to you.
Perfect. So thanks very much to Mr. Galetz and his colleagues for the opportunity to speak with everyone. So I'm Alistair Smith, as he mentioned. I'm an anesthesiologist for the Huron-Perth Healthcare Alliance, and I'm centered mostly out of Stratford, Ontario. I've worked in a few other places that I'll talk about a bit later. And I'm here to talk with you a little bit about my occupation as an anesthesiologist, what it took to get here, things I like about the job, things I would caution about the field and stuff, and answer any questions that anyone has. So basically, in terms of what an anesthesiologist does, the short version that you hear from a lot of people is we're the people that put everyone to sleep for surgery. I often say that anyone can put people to sleep. We get paid to wake them up. Anesthesiologists operate primarily in operating room settings. And our job, a little bit of a longer description of our job, is basically keeping patients asleep and pain-free during surgery, and then making sure that their vital signs stay as normal as possible when something very not normal, i.e. surgery, is happening to them, and then make sure that they wake up comfortably and go home safely afterwards. Some other areas that people might not know that we work in often are obstetrical anesthesia. So pain management for expecting mothers in labor, so things like epidurals, and if they end up having C-sections, we're the people that provide pain relief for them during those procedures. We're also involved in pain management, and that can take a few different avenues. We can be doing acute pain management for people who've just had surgery and dealing with their pain in the sort of the hours to days after their procedure. We can deal with chronic pain management for people that have chronic conditions like chronic headaches, chronic pain syndromes, that type of thing, and that can deal with either medical management or interventions like nerve injections and other kind of fancier modalities. And I can also deal with pain and symptom management in palliative care settings for patients who are unfortunately having at sort of end of life and need pain and symptom relief from their illness. The last area that we are often involved in is critical care and intensive care units, which has been topical lately, as I'm sure everyone's seen on the news with COVID and the ICU surges that the country as a whole is having. Anesthesiologists are kind of at the forefront, and so we're involved with airway management and making sure that these patients who need to be connected to breathing machines and ventilators can be connected to them and maintained on them in a safe way. And so I've been involved a little bit with that here. I have colleagues who are involved in the Toronto area as well, which has been hit really hard. So that's been a big portion of our job for the last several months to year or so. And we kind of operate in the background. Not a lot of people really understand what we do, and I'll talk a little bit about the pros and cons of that afterwards or later on in the presentation. So in terms of skills that I think contribute to being successful or a good anesthesiologist, I think you have to be able to integrate information and solve problems quickly with that information. I think you have to display good leadership, and some of that can be trained, and some of that might be a little bit innate. There's situations where when things really hit the fan and things really get ugly, we're kind of the direction that people look to sort of take charge of the situation and lead crisis responses and emergency management. And I really enjoy that responsibility and that sort of pressure. But it's not for everyone either. But yeah, we have to be able to lead teams effectively and get buy-in from our colleagues and things like that. A certain amount of manual dexterity is required, although, you know, Mr. Gletz would certainly be able to attest I wasn't winning any athletic awards in high school and stuff. But you do need a certain amount of manual dexterity to do the job, because a lot of what we do is manual stuff, or is technical things like intravenous's, spinal anesthetics. We're working in fairly delicate areas, and we're dealing with distances of, you know, millimeters between fairly sensitive structures. In terms of traits that I think are beneficial, I think you have to be fairly analytic. You're going to see some of the monitors that we operate with on a daily basis, and there's a lot of information going on in them, and you have to be able to sort of analyze that information, understand what it's telling you, and put it in the context of the other information that's available, and use that to make decisions, you know, to care for your patient. I think you have to be able to deal with high pressure and high stress situations in a calm fashion. Because like I said, when things really sort of hit the fan, we're the direction that people look to. And, you know, we use the analogy of air travel often, but if you're in a plane and you see the pilot panicking, it doesn't inspire confidence in the passengers. So even when things get fairly heated in difficult situations like traumas or gunshot wounds and stuff like that, when we're dealing with fairly high stress situations, we have to be calm as we analyze and deal with the situation. I think you have to be able to work in a team setting, both as a leader and as an effective follower. There are times where we're often collaborating with our surgical colleagues, particularly in emergency situations. And you have to be able to play as an effective member of that team. And I put kind of 2 stars or asterisks besides this one, personable, because oftentimes people lump anesthesia in as the people who don't enjoy other people. They just put people to sleep, and we just kind of sit in the background and do crossword puzzles, which I think, I'm biased, of course. I don't think that could be further from the truth. I often use the example that, you know, in other specialties in medicine, for example, internal medicine or family medicine, or even surgery, you have a clinic and you see patients for days and weeks and months on end, and you have a long time to build up relationships with those patients. There are times where I see a patient for 5 minutes before one of the highest stress situations that they're possibly ever going to go through in their life. And I have to build a relationship with that patient in a very short period of time and get them to trust me, at times trust me with their life for that very, very high stress situation. And I think it takes a skill set to be able to do that effectively. And I think you really have to try and relate and empathize with people to be good at that aspect of the job. In terms of personalities that are sort of best suited, in my opinion, to the profession, I think you have to be very self-motivated. We're a profession where I sometimes tell patients, if they say they don't remember me and I see them down the road, I said, you know, if you don't remember me, it means I probably did my job well. Patients are often asleep for their procedures, or at least sedated for their medical procedures. And at the end, they'll see their surgeon and follow up, and they'll see their primary care physician and follow up. They don't always see us and follow up. So we don't get, you know, little gift packages and thank you letters and stuff like that. So you have to be the type of person that can be content with doing your job to the best of your ability, knowing that if that patient comes through their surgery pain-free and comfortable, that's enough reward in itself, and that you don't need a lot of external kudos for your job. I think you need a broad interest base. So in anesthesia, we deal a lot with medications. We deal a lot with physiology, which is basically how the different systems of the body work. I also have to know a fair amount about the surgery that's actually going on the other side of the table, because there's certain times where what the surgeon does really affects what I have to do as an anesthesiologist. And I have to be able to anticipate their next steps, and I have to be able to, you know, if they're doing a surgery with cameras where I can see things on the screen, I have to kind of recognize where, you know, things are looking like we might be getting into some trouble here, or they're nearing this step and I need to do this as my next steps because of it. I think you have to be a reasonably calm person, or at least be able to pretend to be calm. I use the analogy of a duck, you know, like the duck looks really calm on top of the water while its feet are paddling away underneath. That's kind of a good description of what we have to do sometimes. And I use this last line because I tell people, I've been an interviewer both at the student level, the resident level, and as now a staff level for medical school applicants. And I really truly believe that good people make excellent doctors more often and consistently than good students do. And so I think it's one thing to be able to get good marks and things like that, but I think you need to do activities and volunteer experiences and other experiences to broaden yourself as a person in addition to studying hard in school, and work hard to be able to relate and empathize with your patients, and that will make you a more effective physician than any 100% on an exam could ever do. So this is basically where I work. This is a picture of our front entrance at Stratford General Hospital. For anyone who doesn't know, one of Stratford's claim to fame is the theater that we have here. So we have one of Canada's largest Shakespearean theaters, and we also do a lot of modern theater as well. The other claim to fame that we might be better known for now is we're the home of Justin Bieber. And so I was searching for a picture, unfortunately, one of my nursing colleagues, because Justin shows up at the hospital from time to time. And one of my nursing colleagues had a picture of her with him outside the front entrance from a couple of years ago when he showed up for a random visit the one time, but I couldn't find it in my phone. So you'll just have to take my word that he does show up from time to time and visit the hospital and stuff. This is my quote unquote office, so to speak. So we don't have, as an anesthesiologist, unless you're involved in chronic pain or other situations where you're going to have a fair amount of patient follow-up, you don't necessarily have an office with files and a secretary and any sort of thing like that. My office is in an operating room. And so that means I'm fairly portable. Means I don't have a lot of paperwork to travel with me, if I decide to move locations of my job and everything. An operating room is pretty much an operating room. There's some that look different than others and stuff. This is a stock Google photo that I grabbed. I do have a picture of our operating room somewhere later in the presentation here. But they all look fairly similar. This is sort of my position at the head of the bed here, while the surgeons are on their other side of the drape performing their procedure. And I'll talk a little bit about what the giant machine is beside me, what it does, and how integral that is to our job. In terms of equipment used, so I'm going to go kind of from low tech to high tech. Medicine in general is a rapidly evolving area. Certainly in the last 40 years, technology has made things much, much, much safer for patients. Even in my career, the evolution or the advent of different technologies that we use have improved our ability to give safe anesthetic care. And I often tell patients now, the statistics show that it's way more dangerous to get in your car and drive to the hospital than it is to actually have an anesthetic for surgery, because people always ask, am I gonna have complications? The worst question is, am I gonna die? And I tell them honestly that, you have a better chance of something bad happening on the drive to the hospital than you do something bad happening during your surgery for most patients. So in terms of low-tech tools that we use for our job, good old-fashioned stethoscope, as you can see around the neck there. That hasn't changed in about 100 years or so. It still does have a function in medicine, although I would argue, and you'll see why later, that function it's kind of evolving out of use. It's becoming a little bit of a relic because we have better options available. Other things that we use often, we have intravenous catheters because we give a lot of our medications via intravenous, and they go from really, really small, like the little purple guy on the right there, which we would use for kind of newborn babies and little tiny people, up to the great big orange one, which is a 14 gauge cannula, which we would use for great big operations like heart operations and operations on the aorta, which is one of the big blood vessels in the body, as well as for trauma cases where things like shootings or stabbings where you're going to end up having to transfuse a lot of blood and things like that. On the right side is pictures of endotracheal tubes and alternative airways and tools for putting those in. So during surgeries, we have to kind of take over physiology a little bit, and we have to kind of take over things that the body would normally do for itself. So sometimes when you're having a surgery, because of some of the medication that you have to get for that surgery, you don't breathe as effectively as you normally would, or sometimes you don't breathe at all. And so we have to have tools available to help you with that during the case, to keep your body working as normally as it can while something very abnormal is happening to it, i.e. surgery. So these are different tools that we have at our disposal to do that. This is another tool that we have. This is something that you would see over in the obstetrics unit. So this is for epidurals, which we use for pain relief for women who are in labor and patients who are having cesarean sections and stuff like that. There's other tools. There are other things that we can use epidurals for as well, but that's probably the most common one. And then we get into some of the more high-tech stuff. So the anesthetic delivery system, which is the big machine you saw in the other picture there. So this machine has a ton of technology packed into something that's about the size of a filing cabinet. This is kind of the bread and butter of how we give anesthetic gases and keep people asleep and help them breathe during their surgery and monitor all their vital signs to make sure their body is functioning properly and that we're doing what we need to do to help it function properly. So this is a generic anesthetic machine. I'll show you the one that we're actually using. So this is from a case I was doing a couple of days ago. So as I mentioned in the skills that I think are essential for this job, there's a lot of information going on that screen. A lot of different waveforms, a lot of different numbers, a lot of different colors. And, you know, if you could hear it in the operating room, there's a lot of different sounds that come from it too. And we have to be able to look at all that information, analyze it, put it in the context of the other information and figure out what it's actually telling us. Everything up there is normal, by the way. I was doing a good job. The other equipment that we use that's kind of higher tech is this is a tool called a fiber optic bronchoscope that we can use. It's basically a very, very small camera on something that's even smaller than a drinking straw that we can use to help put breathing tubes in people where the space might be very, very tight in the mouth or the nose, for example. So things can happen where there's swelling, or sometimes there are certain situations where there might be a cancer there that's providing a situation where you can't easily see what you need to see, and you can use this camera to kind of see around corners and stuff like that. In the interest of patient confidentiality, I'll mention that this is a stock Google photo. This is no patient that I have treated or was involved with at all. And this is I have no idea who this person is. This is literally just a Google search photo. And then sort of the big paradigm shift that's going on in anesthesia right now is the advent of ultrasound technology. And this isn't unique to anesthesia, but I think we're one of the early adopters of it in terms of how it can add to our practice and our ability to treat patients well. And so you can use ultrasound for a lot of different things. I'm showing you a picture of the heart right now. And so if you look on the right side of the screen, that's actually, it's backwards and it's upside down. So there's 4 chambers in the heart, and you can see the left ventricle on the right side of the screen, the right ventricle on the left side. And then at the bottom of the screen, those 2 guys are your left atrium and your right atrium. And if you look at this patient in particular, you'll see the bottom part, which is the top part of the image here, isn't actually contracting very well. Sort of 3/4 of it's squeezing pretty well and pretty regularly, and the top part of the screen isn't. And that can indicate this person actually might be having a heart attack right now. And so there's they're going to need treatment for that. And this can help sort of delineate what the most appropriate treatment is for them. If they come in with low blood pressure and you see this on the screen, you say, okay, well, their pressure might be low because their heart isn't pumping properly. And if I go to the next screen, it's another same view of a different heart, and you can see the 4 chambers again, and you see the heart's kind of bouncing around in sort of this black void there. And this black void is actually fluid that's surrounding the heart. And so this person needs even more emergent treatment. This is a situation called cardiac tamponade, where that fluid is actually squishing the heart. And so that person might show up with low blood pressure just like the previous person, but the treatment's very, very different for that. So this person actually needs that fluid drawn off the heart, which means we would have to put a needle in and then sort of suck that fluid off from the heart. We wouldn't do that. The cardiologists, the heart specialists would do that. But if a patient comes in or a patient's having surgery and we put a probe in their chest and take a look and see those 2 different pictures, that adjusts the treatment that we give dramatically. And I think that's ultrasound has given us kind of a window into seeing things in real time that can help us give the best treatment possible for our patients. The other areas where we'll use ultrasound often is nerve blocks. And so I know I talked about us putting patients to sleep for surgery. One of the newer sort of trends in anesthesia is the ability to do surgery without people going to sleep. And so the less medication we have to use that has consequences and side effects, the better. And so oftentimes we can freeze specific nerves. And so this is a picture of the femoral nerve. So in the leg, kind of in the upper thigh area, and you can see there's 2 blood vessels. There's a femoral artery and a femoral vein there. And then the femoral nerve is just on the outside. And you can see kind of a white line here, which is actually a needle that we've introduced sort of right beside the femoral nerve, but not right up against it. And we can inject freezing medication around that nerve, and that can provide freezing across part of the leg. And so this person might be having knee surgery, they might be having foot surgery, and we can freeze that nerve specifically so that they can have that surgery without necessarily having to go to sleep and feel kind of groggy and everything when they wake up afterwards, which has been a huge tool at our disposal. There's some patients now that are coming for surgery, they're kind of too sick to put to sleep, so to speak. And this provides us a tool where we're able to get those patients surgeries that they need while not putting them at additional risk for the procedure. So in terms of rewards of the occupation that I really enjoy, I think we have a very wide variety of practice. Again, we don't just put people to sleep. In fact, I say the fewer people I have to put to sleep for surgery, probably the better job I'm doing. If I'm able to get people through surgery without having to put them to sleep, I consider that a reward of my job. Same goes for obstetrical cases, for example, C-sections. If we can keep someone comfortable during their procedure and also have them be awake to meet their baby when he or she arrives, that's a really special thing for the patient experience. And I think, seeing a C-section for the first time that was done under spinal anesthetic, where the patient was awake but frozen and comfortable, frozen from the sort of belly button downward and comfortable, was able to sit there with her husband and hold her baby when the baby came out and stuff like that. And it's a very special time for that couple. And I think it's a privilege to be able to provide that for them. I think it's a very dynamic occupation. So there's technology that's changing every day in our specialty. I also think that the breadth of our specialty is changing significantly too. And so we're doing a lot more work in terms of patient assessment before and after surgery. And that's changing frequently now. We're almost like and oftentimes we're behaving almost like a critical care provider for patients in and around their surgeries. I also think you provide anesthetics for a lot of different types of surgery, which I think it's its own challenge. I can go in. The other day, I started my day doing anesthetics for a 1-year-old having a procedure, and then I ended my day with doing an anesthetic for a 92-year-old having a different procedure. And so that's a lot of variety in terms of different sizes of humans and different considerations that go along with that. That keeps me on my toes. It's a different challenge every day at work. I think it's a huge privilege being able to care for patients in high stakes situations. So oftentimes we see patients on in some of the highest stress situations that they'll have. And it's a real privilege to be able to earn their trust and look after them in those situations. We're a very portable job. So like I said, we have no office. We have no long-term paperwork necessarily, unless you're doing chronic pain or one of those type of specialties. And so we can transport, if I decided I wanted to work in a different center, I can do that fairly readily without having to find alternative care for my patient roster and things like that. We have a lot of teaching opportunities, both with residents of anesthesia as well as other professions. So I teach a lot of emergency medicine providers. I also teach a lot of respiratory tech students and the occasional paramedic students as well that come in, which is fun. And I put epidurals in because I think it's a huge reward. I really enjoy obstetrical anesthesia. I think it's a huge reward to be able to go in and provide, pain relief for these patients when they're going through labor, if that's something that they want. Seeing someone that's able to, they're in agony and they're not able to cope with the discomfort and everything, and you come back in 10 minutes later after doing an epidural and they're sitting up doing a crossword and drinking a Kool-Aid, or drinking a ginger ale or something. It's really rewarding to be able to provide that service. Challenges of the occupation. I don't know if anyone watches The Residents anymore. I don't know what, I must admit, I don't know what kind of medical dramas, if any, high school students are watching these days, but I threw it up there because if I put Grey's Anatomy up, it was really going to age me. Or ER even. There's a long pathway to get there, so we'll talk a little bit about the educational requirements in a minute. The schedule can be unpredictable, so even today, there were a couple of emergencies at the end of the day that pushed me a few minutes late for this presentation even. And that's sort of out of my control, and we have a certain responsibility as healthcare providers. The patient always comes first, and there are times when it's frustrating for my wife and my family and my friends when they say, when are you going to be home? And I said, I'm not sure because I have to wait and see this case through. I can't, it's not something I have control over. My day is done when the surgery is done. There's no protected weekends or stat holidays. I think if you're getting into medicine for the lifestyle, that it might not be the profession for you, in the sense that there are different specialties within medicine that have pretty good lifestyles. But as a whole, it's a profession where, like I said, the patient comes first, and you have to be willing in a lot of different specialties, especially anesthesia. I do 24-hour call shifts, and I have to be willing to get up at 3 in the morning and do cases at that time. There are times where I'm going to be on call on Christmas Day, and I'm not going to be able to be around friends and loved ones and stuff. And that's not all the time. Most of the time we still do get a reasonable amount of time off, but there are situations where that's the requirement of the job. And that's just something you have to go into with open eyes. It can be emotionally challenging. So the vast majority of the time cases go well. When cases don't go well, that can be very difficult, because we often, fairly or unfairly, bear a lot of that, bear some of that heaviness, because we often work by ourselves. So we don't work as, we work as part of a team with our surgical colleagues, but we're the one anesthesiologist providing care for that patient. And if something untoward happens, it can be a very, very emotionally difficult thing to deal with. And so it's important to have a good group of colleagues and friends and support systems that can work you through challenging times, because difficult cases do happen. There's some things that happen that are way out of your control, and it's important to know how to deal with that when those things do happen. And the other thing, like I said, is not many people really understand what we do. I would say about maybe a quarter to a third of my patients don't realize that an anesthesiologist is a doctor at all. And so you can't be the type of person that gets your back up and lets that bother you. I tell my patients they'll start with saying Dr. Smith, and I say, just call me Alistair. I don't worry too much about titles or hierarchy or anything like that. I think it's a privilege to be in the position I'm in, working with great people and things like that. And if you're the type of person that wants to take a lot of pride in a title, or needs a lot of external validation or recognition for what you do, then our profession might not be one where you get a lot of that, with the exception that we are highly, highly valued within the hospital. So, our colleagues in medicine, our emergency medicine physicians, our critical care colleagues, our surgeons know exactly what we do and value us tremendously and stuff. But from a greater public standpoint, we're not well understood. We're kind of this black box enigma, so to speak. So salary and benefits. This is kind of one of those things that not a lot of people will talk about in medicine. And I think it's kind of taboo in a lot of different areas. People don't like to talk about income and stuff like that. And I think that's a bit of a disservice, because I think you have to walk into any profession with eyes open, because every profession has perks and drawbacks. So I think in terms of salary range, what the average anesthesiologist in Ontario would make, and it's similar in Saskatchewan, that's why I left it as a fairly broad range. If you're working full-time, somewhere between $300,000 and $700,000 in a year. If people are dealing with chronic pain and have their own clinics and stuff like that, there will be a handful of people. I think there's maybe 10 or 15 people in Ontario that are billing well north of 700. Sorry, I should say in Ontario, there's a handful of people that are billing upwards of $1 million. They are very much the exception, and I would cautiously submit that those people are probably not, I don't want to use the term disingenuous, but it's very uncommon to have that high a billing. I'd say that this is a fairly average representation within our province and probably within the country. The reason that I put the star beside that is for all of the points below. And so that sounds like an awful lot of money, and it is a very, very comfortable income. And I would never for a second claim to be hard done by with my income or my profession or anything like that. I feel very, very privileged to have a secure income like that, to be able to provide for my family. With that said, that money doesn't end up in my pocket. Most of that money ends up in my corporation, because that is what funds my retirement plan. Because I don't have a pension and I don't have benefits. And so money isn't withdrawn off my paycheck every month to plan ahead. And so you don't necessarily have to plan ahead. If you want to work until you're 80 years old or whatever, and you want to just spend what you make and everything, you don't necessarily have to do that. But if you're the type of person that wants to be able to retire and wants to have a comfortable lifestyle when they retire and things like that, you have to set aside a fair amount of that money in investments and things like that to be able to plan for your future and your family's future. And then there's, I won't get into taxes and everything like that, because every occupation pays taxes for the most part. So But yeah, so you have to, if you're someone that's not good with saving money, you have to kind of teach yourself to set aside a good portion of the money that you're making, because you're gonna need it later on. And the other thing I should add is that while that money provides you with a very comfortable and stable income, because of the training required, you will not be earning that income until probably your early to mid 30s, and that's if you get into medical school relatively young. And so there's a lot of occupations where you can start working at 18, 19, 20, 21 years old. And you'll make less than that, but you'll carry less debt, and you will have the ability to save for retirement for a longer period of time. So there are benefits and there are drawbacks to everything. There are no protected holidays. Like I said, we provide call services 24/7 at the hospital. So one member of our group, we have 8 in our group, and one member is providing call on Christmas Day. One member is providing call on Good Friday. One member is providing call on New Year's Day. And so there's always someone on, which means that 7 out of 8 of us will have that day off, but it's a trade-off where eventually the schedule will come and it will be your turn to work that day. And that just has to be something that you recognize and accept as part of the job. I would say typical work hours once you're out of residency hover somewhere between 45 and 65 hours a week in my profession. We put in some long days sometimes in the OR. Occasionally we'll do 24-hour calls. Sometimes we'll do a little bit more than that, which can make it higher. And there are days where we get home early and it's less than that. And so it all kind of comes out in the wash. Residency, regardless of specialty, you will oftentimes put in more hours than that, but it's a means to an end. So in terms of educational requirements, your main requirement from high school is to graduate. Take whatever courses are required for your undergraduate degree of choice. This has changed a little bit. I had to kind of review some of the most recent admissions criteria because this changes regionally and this has changed with time. When I applied to medical school, and this is a few years ago now, they required specific courses as prerequisites. So for example, we had to have first year physics in university, and to take first year physics in university at the time, you needed high school physics. Those specific courses aren't required anymore. I would suggest that if people are interested in a career in medicine, that a lot of your high school courses are probably going to be science focused naturally, just based on the fact that you're interested in medicine. But we had people in my medical school class. We had someone who was an English history major. We had someone that played for the Saskatoon Symphony Orchestra, who was an awesome cellist. And we had I know someone who was a Russian literature major in undergrad who got into medical school. And so those people make awesome doctors too, because they carry a breadth of experience behind them that those of us who were science heavy didn't necessarily have. But yeah, most schools now don't require any specific courses to be able to apply for medical school. So take whatever courses you find interesting and we'll set you up for whatever undergraduate degree you're going to pursue while you're considering applying to medical school, would be my advice. Post-secondary options for training. Some schools will allow you to apply after 2 years. Some will require 4 years. So the University of Saskatchewan now requires a 4-year undergraduate degree. That has changed since I applied. I only took 3 years of undergrad. I didn't actually finish my undergrad degree, and I was fortunate enough to get in fairly young. Some schools will still allow you to apply after 2 years. Some will say you have to have 4 years. Sometimes people will take more years than that to apply. So we had a couple people in my medical school class with PhDs who had already been in school for 6, 7, 8 years before they got into medical school. And if they decided it was something that they wanted and they were determined for that, then keep plugging away at it. There are 17 Canadian universities that offer medical degrees. 13 of them are English. One of them is bilingual, which is Ottawa University. And there are 3 which are primarily francophone, which is Sherbrooke, Laval, and UDM, Université de Montréal in Montreal. There are international options for medical school as well. Some of those are direct admission, and so you can get in directly out of high school in some schools in Australia. And some require degrees and whatnot first. So I have a number of friends who went to medical school in Ireland. There's some options in the Caribbean. Just be wary that going there as an international medical graduate, trying to come back to Canada can be difficult in terms of getting residency positions and things like that. So again, it's neither good nor bad. It's just something that you have to walk into with eyes open. You graduate from medical school with an MD degree, a medical doctorate degree. And our dean at the University of Saskatchewan, Dr. Bill Albritton used to say that we are the only college that graduates someone with a degree that is entirely useless. And I don't mean that pessimistically, but you can't practice medicine with just an MD. So you get your medical doctorate degree, and that sets your foundation for what you're going to do next. So in order to practice medicine in Canada and the States, basically anywhere in the world that operates in the same system, you have to complete a residency. That residency can vary in length from family medicine, which is 2 years, and then sometimes you can do a third year in emergency medicine or other subspecialty areas. Pediatrics is 3 to 4 years. Internal medicine is 4 to 6 years. Anesthesia is 5 years. General surgery is 5 years. Cardiac surgery and neurosurgery are 6 years. And so it can vary in length depending on what you want to pursue. Once you are done your residency, you write something called your Royal College exam. And then you get 5 letters after your name that'll be either a Fellow of the Royal College of Surgeons of Canada or a Fellow of the Royal College of Physicians of Canada, depending on if you're in surgery or if you're in a medical specialty. So in anesthesia, at the end of our 5 years, we write a 2-day long exam. So one day is a full day from basically 8 in the morning till 4 or 5 p.m. At the time, at least, written exam where there's a multiple choice component and a short answer component. And then we come back 6 weeks later and we do an oral exam where they give you scenarios and you have to talk your way through it and say how you would manage the situation. And at the end of that, you find out a couple weeks later if you were successful or not. Fortunately, the majority of students in Canada, we have very, very good training programs in Canada. And the majority of students in Canada in anesthesia are successful with that exam. So the pass rate is upwards of 93, 94, 95%. And part of that is because we work our butts off. And part of that is because our training programs are very, very good and very standardized. The 2 pictures here I included, so these are 2 of the centers I trained at in Ottawa, where I did my residency. So this is the Ottawa Civic Hospital on top, which is a very cool older building. And the bottom one is the Ottawa Heart Institute, where we do cardiac surgery and stuff like that, which is actually on the backside of the Civic Hospital. So educational requirements after residency, if you're a real glutton for punishment, you can do subspecialty training. You could specialize in something like pediatric anesthesia, where you want to go and work at a children's hospital, for example, giving anesthetics to small children and things like that. You can work in critical care if you want to do intensive care unit stuff. You can do obstetrical anesthesia, where you want to bring an extra skill set to being able to look after moms when they're going through labor and having C-sections and stuff. And sometimes required for jobs, there's a bunch of other fellowships you can do as well. Those are just a handful of them. And sometimes required for jobs, especially in academic centers, places that are tied to universities, they may require a master's degree or a PhD. And that's just unfortunately the job market nowadays. Things are changing, and so that's not as much the case anymore. But certainly when I graduated in 2017, if you wanted to get a job that was attached to a university, they would want you to go and get a master's degree of something like epidemiology or quality improvement, which was going to be potentially another year to 2 years, which you can sometimes do while you're working, but it does stretch out, again, your time commitment to training. So I'm going to go through my journey pretty quickly here, so then we can get into sort of the work-life balance stuff. I graduated from Rostam Central High School, and I'm pretty sure it was in 2005 or 2006. It's a while ago now. I joined the University of Saskatchewan and did arts and science for 3 years, majoring in biochemistry and physiology. And at the time, I was considering education, medicine, pharmacy, and I was trying to juggle sort of pros and cons of each of those jobs. And I eventually settled on applying for medicine because I realized that there was a certain component of education that I could complete within medicine. We have a fair amount of opportunity to teach, and it was easier to have education as a hobby and medicine as a profession than the other way around, obviously. I applied to medicine after my 3rd year of undergrad because I took a couple years to kind of really figure out what I wanted. And I was fortunate enough to be admitted in my first application. I would say I was very fortunate, and that's not always the usual path. Sometimes people have to apply a couple of times, and that doesn't reflect good, bad, or otherwise on the physician that they become in the end. I graduated from the College of Medicine in Saskatchewan in 2012. And this is actually a picture of some members of my class. I'm the little dorky guy on the left here that looks like he's about 12 years old with glasses. I moved to Ottawa in 2012 to complete my anesthesiology residency there. So during medical school, I worked in, you can do electives in different centers. So I worked in St. John, New Brunswick. I worked in Edmonton, Calgary. I spent some time down in Regina. Actually, a fair amount of my rotating clerkship was in Regina. I had worked out in BC for a little bit, and I had worked in Ottawa, and I really enjoyed my time in Ottawa, and I liked their program. So I moved there after applying for the residency program in 2012. My plan all along was to return to Saskatchewan and potentially work at the Children's Hospital actually when it opens, or also potentially return and work in Regina afterwards. And then I met a girl from Ontario, and the things we do for love. And so this is my wife, Maddie, on the right side of the picture there. We're at a Blue Jays game there in that picture, obviously. So you can have some fun in residency, even though the hours can be long. You know, we tried to figure out a place that was going to be best for us to settle. And she's from Ontario with fairly deep roots here. And so we wanted a place that kept us close to her family for family reasons. And we also wanted a place that was a little bit more rural to remind me of some of the stuff that I missed from Saskatchewan. So we ended up in Stratford down here, which is a lovely little community, and we've really enjoyed it. And I started full-time in Stratford in 2017 and have been here since. I've also worked in Peterborough and some different centers in Ottawa and in Thunder Bay as well. And so I've bounced around a little bit, and we're very, very fortunate to be where we are right now. I really enjoy it. Job market is always hard to say because, like we've talked about, the road to get there is long. So you're talking minimum of 12 years, 11 to 12 years, depending on if you're very fortunate to get in early. So the residency alone, you know, even from the time when you get into anesthesiology residency, it's going to be potentially 5 years before you're done. And so it's hard to know what a job market is going to look like 5 years down the road. So I often tell people, pick a specialty in medicine. Don't pick it based on a job market. Job markets can be tight, but if it's something that you love, you will find a way to make it work. And there are jobs available for the right people. So work hard to make yourself the right person, and there will be jobs available for you. I can say that with the caveat that right now the job market is opening up significantly. And so there are opportunities, especially community-based opportunities for people that didn't exist even 3 years ago when I finished residency. Chances for advancement, I think that really depends on what direction you want your career to take, whether you want to practice in an academic center, which means that you're tied to a university, versus a community center, which is what I'm practicing in right now, where we're not on, the University of Western Ontario, or Western University is in London, Ontario. We are not on their campus or anything like that. I am an adjunct professor with with Western University. So we do have some loose ties to them, but I don't have the same degree of research requirements and things like that with my job. And so depends on which avenue you want to take in terms of advancement, where you want to go. If you want to be a big time researcher and publish a lot of papers and do a lot of investigations, that's available to you. If you're the type of person that wants to be a worker bee and come in and do your cases and go home, that's also available, and that's great. And there's administrative pathways as well. So the CEO of the hospital where I trained at in Ottawa, Dr. Jack Kitts, was an anesthesiologist prior to sort of parlaying his career into administration, and that's available for us as well. What could this occupation lead to? Well, it can lead to hospital-based work, which is what I'm currently doing right now. You can do sort of some out of hospital stuff like chronic pain clinics that we talked about a little bit, which is really kind of the only out of hospital home for anesthesia right now that I'm aware of. But then there's also things like administration that you can get involved with as well to kind of broaden your skill set. And there's things like you can go and work for different medical organizations, like the medical legal group that protects physicians if we're involved in legal issues related to the work that we do and stuff like that. I would say related occupations, I kind of broke these into MD occupations and non-MD. So if you want to go to medical school and you want something that's anesthesia or anesthesia related, I'd say the closest stuff related to us is critical care, which you can access through various different pathways, including emergency medicine, general surgery, or internal medicine. I would say emergency medicine is fairly closely related to us in terms of they deal with highly acute situations. And I would say palliative care and symptom management is fairly related to us. And you can actually do palliative care after anesthesia if that's as a fellowship option, if that's something that interests you. I would say non-MD related occupations, if you're the type of person that kind of enjoys the the type of stuff we do, but don't want necessarily to go through with medical school and everything. Respiratory technicians work very, very closely with us, and they can actually go on and train to become what's called an anesthesia assistant, where they work very, very closely with us. And they're super valuable members of our team, and I think that's a really great occupation. You can be a nurse anesthetist, which is more of an American profession than a Canadian one right now. And it's a little bit of a complex issue to unpack. So I won't get too much into it, but they may be coming to BC in the not too distant future. And time will tell whether they kind of spread across the rest of Canada or not. For now, it's more of an option in the States. And if you want to do paramedic training, especially things like advanced care paramedics and things like that, deal with some of the same airway management and sort of resuscitation and stabilization stuff that anesthesia does. So in terms of life-work balance, I think it's basically, in medicine in general, it's kind of what you make it. It's, oh, hang on here. My text disappeared off that slide. Let's just go back here. Within medicine, anesthesia is a very lifestyle-friendly specialty, or it's seen that way. You have the ability to leave work at work. I don't have charts that I have to come home with or anything like that. My work at work is stressful, but when I come home, I know that I've done my job. I've handed off my patient to my colleagues, and they're in good hands. And I can spend time with the things that I find the most important in life, which is my family and my friends and things like that. So this is kind of our 2020 journey here sequentially. So that's my wife, Maddie, and that's us leaving the hospital with our little guy, Hugh. Mr. Gletz will be happy to hear his name is Hugh Albert Bruce Smith. The acronym or the mnemonic that spells is HABS, which was totally unintentional, but I'm a Montreal Canadiens fan, so I'll take it. We don't know who he's cheering for yet. He kind of just looks at the TV and giggles, but it's a ton of fun being able to come home and leave work at home and spend time with my family and have an occupation that allows that. There we go. I think a lot of your lifestyle factors for medicine in general depend on personal choices. So you can make your career as much of a focal point or as little of a focal point to an extent in your life as you want. And so I think you have to make time for the things that are important. Within anesthesia and certainly within medicine, I would say community practice is a little bit more flexible and accommodating in that regard than academic practice. So when I come home, for example, I don't have research requirements that are hanging over me. I don't have deadlines to meet in terms of publishing papers. I have other deadlines to meet and things like that. But I chose the career path that I chose within anesthesia partially because it allows me to spend time doing other things, because I have a pretty broad set of interests, and I enjoy the opportunity to keep doing those things. So like I said, important to have interests outside of your career and to make time for those things. So like I said, my number one thing that I'm interested in is obviously spending time with my family. They're the most important things to me. Other things that I do outside of medicine, I bang away on the guitar quite a bit, and so I've got my little man cave down in the basement. My wife gets the fancy loft and everything for doing yoga and things like that, and I relegated to the basement, but I'm quite happy down there. So yeah, I play guitar quite a bit. I collect vinyl records, and I'm training for I'm training for some official wine certification stuff. So I've done a couple levels of my sommelier certification, and some certificates in Ontario wine and things like that. And those are just hobbies that I do on the side, and I'm grateful to have a job that allows me time to do that. I also volunteer on the board of directors at a community food center here in town, and my wife operates as one of the fundraising directors for that same community food center. I love watching sports. I play rec hockey. Back pre-COVID, at least, I play rec hockey once a week with some colleagues from the hospital. I play soccer a day a week with some colleagues from the hospital as well. And so we have a job that allows us to do those kind of things. And I personally feel very, very fortunate to have the balance that I do in my career. So I hope that's given you a little bit of a spotlight into to what I do, what I like about it, what I might caution about it, how I got here, and yeah, and where I am presently. And I'm happy to take any questions from anyone.
That's awesome, Alistair, and I'm glad you let me call you Alistair. I wasn't quite sure. I'm glad you took that approach to it, because it's hard for me to see you as anybody but Alistair. Anyways, a couple of questions I had. Very good presentation, very thorough, for sure. But residency, can you explain how that works? How do you choose a residency, or is there an application process, or how does that work?
Yeah, so when you're in medical school, most medical schools in the country are 4 years. There are a couple that are three. So McMaster and Calgary are two schools that have a 3-year medical school degree, and they do that by not having a summer. They go right through summer, and the reward for that is getting done a year early. Regardless, when you're about 3/4 of the way through medical school, by that point you're doing rotations in hospital. You start to apply to something called the Canadian Residency Match Service, or CARMS, where you make a list of specialties that you've been interested in and that you have exposure to, because you get some time to rotate through all the different specialties. And then you line up a bunch of reference letters and you write some applications. And it's very similar to applying for a job, really. And you submit those applications to the different schools. And so for anesthesia, there were 13 English-speaking anesthesia programs. And I'm unfortunately not bilingual, so the French options weren't an option for me, but I applied to all 13 programs across the country. And I was fortunate enough to get interviews at all of them. And so I went, and then in your fourth year of medical school, you go on your interview tour. So wherever you're offered interviews, you jump on a plane, and I went coast to coast. I went from Signal Hill in St. John's to Vancouver, BC in a period of 2.5 weeks. And you interview at these various centers. Sometimes you're interviewing at 2 places in a day. So one in the morning, one in the evening. And then when that's all done, you submit your list of your rank list of the places that you would like to go. And they submit their list of their applicants and who they would like. And there's a fancy computer algorithm that matches those things up and tries to find the best fit for each.
Is everybody in medical school guaranteed a residency, or is that?
No, and so that's a good thing that you brought up. So unfortunately, there are enough residency programs in general in the country. There are more residency programs than there are medical students, but there are not more residency programs than students in every specialty. So for example, countrywide, we have about 100, and at the time at least, when I applied, there was about 115 English-speaking positions for anesthesia residencies. And there were around 160 applicants for those. And so some of those applicants who don't match to anesthesia will have also applied to other areas. And so I know someone who probably would have matched to anesthesia if they wanted to, but they had also applied to a different specialty, to obstetrics, and they ended up matching obstetrics higher in their list. That was their preference. And so they matched to obstetrics instead. But there are some people who unfortunately don't match to one. And there are options that they still have available, as hard as that situation might be.
Good. That's a good answer. I'm glad I asked that. Another question I have, and I don't know about statistics or anything like that, but I always wondered as a career counselor, I think you and maybe Mike Smith, which again, both Smiths and both from the same grade, are about the only two that I can recall in Rosetown that became doctors. There might be some more that I just can't think of now. But is there a rural issue, or is that just, those are statistics, that's not a bad average?
Yeah, sorry, you're going to hear some
no, that's all fine.
some babbling in the background. Can you see me right now, or does it just show the PowerPoint?
No, I can see it. No, that's
okay.
Good. That's fine to have.
We'll bring you up to help with the answer. There we go. So it is a bit of a, so I think it's very much an issue. And that was one of the things that I was trying to tackle in med school. That was what some of my research was based on, was rural applicants. And in particular, there's pretty good data to show that some of the better options for getting increased family doctors and increased providers in rural areas is to get students from rural areas into medical school. And so I think there's a lot of work to be done still in terms of getting students from those backgrounds in getting them to a position where they're not disadvantaged in terms of their applications. There's a couple others from town, actually. So Jaden Cowan is an anesthesiologist in Saskatoon now. And then Denny Johnson ended up doing family medicine. And I think he did emergency afterwards, but I'm not sure where he's practicing now. So we're actually fortunate for a small town. We've had a handful of people in a few years do fairly well.
I did forget about those two too. Yeah, there are two others. But it seemed like a lot of not that I was, as a career counselor trying to push people into one thing or another necessarily, but some people that when they talked about medicine, or if it would show up on some of their, career skill assessment things, medicine, and they seem to be like, no, I'm not going to do that. No, don't want to do that. And I think some of them were shying away from the length of time. I get it. It is a long time, but I mean, there's rewards at the end of that.
Yeah, no, I absolutely agree, and it is a big commitment, and it's something that you should walk into with eyes open. And that's why I said at the start, if you're people will see that range of income, and that's those are numbers that people aren't used to seeing in high school necessarily, and things like that. But there's trade-offs for those numbers, and I would suggest to people that if medicine is something that you think is prestigious and you want to get into it for either the income or the lifestyle afterwards, that there are much quicker ways to achieve those incomes and lifestyles. There has to be something else that drives you to do the profession.
And when I meant rewards too, I meant more the rewards of the kind of occupation it is, how important it is and that kind of thing.
And that's the most important thing at the end of the day. You have to love what you do and find reward in the work that you're doing.
Yeah. Are there any other questions from Burnett or Doug?
Yeah, we do have a couple from the office here. One question, at what point in your education, and I think you kind of addressed this, but did you decide on anesthesia as an anesthesiologist? And do you have any of those subspecialties that you talked about?
So I decided fairly late. Most of the time now, students will have a pretty good idea of not pretty good, but they will start to have an idea of what they want to do probably by about early second year in medical school. When I got into medical school, 90% of my exposure to medicine at that time was the family doctors that I had seen growing up, mostly as a patient. I have an uncle who is a surgeon in Edmonton, but saw him a couple times a year maybe. So didn't really have any exposure to his career or anything like that. I was going to do family medicine for about 3/4 of my medical school. That was my plan. In fact, I was fortunate enough I won the family medicine award in medical school, but it was only after I had actually decided to do anesthesiology. And so I felt like a fraud accepting it. I changed gears a little bit later because I recognized in my own personality that I wanted a career where I didn't necessarily bring things home with me. And I knew if I did family medicine, I was going to go and practice in probably a rural and northern setting. And I'm the type of person that probably wouldn't take as many holidays as I could, and would feel guilty if I took those holidays, and would bring things home and I would worry about my patients. And I knew that wasn't sort of a healthy or sustainable way to practice. And so for my own personality, I wanted a job where I can do my job, look after my patients, and go home at the end of the day knowing that I had done my part to look after them and stuff.
Awesome. Thank you so much for that response. And
sorry, there was a second part too that I...
Yeah, just about if you had any subspecialties too.
Right. Yeah, so I changed gears on that one too a little bit. I was signed on to do a pediatric anesthesia fellowship afterwards. And I really enjoyed doing pediatric anesthesia. I realized after I had signed on to do that fellowship that, number one, there wasn't necessarily a job guaranteed at the end of it. And I had looked into that, but the place where I was going to do the fellowship was also looking for someone to do a PhD or a master's degree afterwards. And that would be an extra 2 years after, with, again, no guarantee of a job after that. And I was at the point where I was, nearing the end of my residency and kind of ready to start working and not necessarily commit to another 3.5 years of training, especially if there was going to be no guaranteed job at the end of it. And so I decided to transition to community practice, where I get to do a little bit of everything, including pediatrics. And so, I'm not doing some of the crazy stuff that they'll see at sick kids in terms of very, very complex pediatric stuff, but I still get to do very rewarding pediatric cases in a community setting. So I still get to deal with pediatric anesthesia, as well as all of the other stuff that I still enjoy.
Awesome, thank you. And there's another question from our office here.
Yes, Alistair, my question is mainly financial. You indicated that you don't have a pension plan. You don't get benefits, so there's no health benefits when you work at a hospital. And finally, with practicing for doctors, I know that you have to carry extra insurance, so there's costs there. Can you speak to some of that a little bit?
Yeah, so I'll start with the pension plan and everything. So there is some work. So by the time any of the people hearing this video are considering applying to medicine, it could be a different world. But there's some work being done on physician pension plans, so to speak, where you pay into a pool with every paycheck, and it works like any other pension plan essentially. But it would be an opt-in one, so you wouldn't be necessarily committed to it. I take a certain portion of my paycheck every month, and that goes into savings and investments and stuff, the same way it would if it were in a pension plan. I just do it on an individual basis rather than as part of a collective. As far as and so I have to try and be responsible with my income to make sure I'm setting enough aside that I don't have to work until I'm 85 years old, because I want to be able to enjoy retirement when I'm still young enough to spend some good time with my son, and if we have any other kids, that type of stuff. As far as health insurance and benefits and stuff like that, they're not provided by the hospital because it's a little bit of a unique situation that physicians are in, where we work at hospitals and we're granted privileges in hospitals, but we're not officially an employee of the hospital. They grant us privileges to practice there, but we are effectively self-employed, and the billing, when we provide services, we bill the government, the provincial government, for those services. Our provincial group, so in Ontario, it's the Ontario Medical Association, and in Saskatchewan, it's the SMA, provides, at least in Ontario, there are insurance plans through those groups where you can buy medical insurance, or buy drug plans, and buy dental insurance and eye coverage. Both my wife and I have terrible eyes, so obviously we've got our own insurance plans that cover costs for that type of stuff, but we pay that out of pocket, whereas normally it would sometimes be automatically deducted off your paycheck. It's just something we have to do consciously. I don't consider it a disadvantage because it's not an exorbitant amount of money or anything like that, but it's just something you have to be conscious of and go into with open eyes. And the last question was medical legal insurance, I believe, right?
Yes.
Yes.
Yeah. So medical legal insurance. So you're absolutely right. So there's a group called the Canadian Medical Protective Association, the CMPA, which represents physicians if we're involved in any situations where there are lawsuits that have named us in them. We pay dues to that organization, to the CMPA, and I'll be fairly transparent with what I have to pay. It differs per jurisdiction and per specialty, and a lot of that depends on how much medical legal action there has been against that specialty. So some specialties are much more involved just by virtue of what they do. They're involved in higher risk situations, which have a higher likelihood of sometimes things happening where there end up being lawsuits afterwards, and some are involved in very low risk where there's not a lot of lawsuits. I pay, so some areas will pay $10,000 in a year, some areas will pay $35,000 in a year. Some provinces will reimburse part of that, some don't. And so it's a wide range of amounts that you have to pay to cover it. And the same thing goes with, we're lucky in anesthesia that we don't have clinics or overhead unless you're doing chronic pain. But if you're a general surgeon or you're a family physician or anything like that, then you have a clinic to pay for and a secretary to pay for, and potentially nurses who work at your clinic to pay for as well. And all that comes out of that pool above.
One more question regarding pay. As a resident, do you get paid when you're doing your residency?
Yes, you do. I don't want to sound pessimistic about this because I'm not. I've never begrudged the money that I was fortunate enough to get. But if you work out the hours worked to the amount that you get in residency for the first couple of years, you're working fairly close to below minimum wage. But you do make an income. There is a salary, and it goes up incrementally year by year. And so by the time you're a fifth-year resident, and it varies by province, you negotiate that provincially. So, I'm not actually sure what the pay scale is right now. It starts off fairly modest in first year, and by the time you're a fifth-year resident, it's not a bad amount of money. It's certainly enough to live off of. And like I said, I have no complaints or regrets or anything like that about that end of things.
Thank you so much. Yeah, I think we're okay with questions here, but boy, we appreciated your time and this presentation. It was very well done. Thank you.
Oh, thank you guys very much for the opportunity.
It was awesome, Alistair. It was good to see you and hear from you. And thank you and all your colleagues for what you're doing with COVID too. It's been a challenging 15 months or whatever it has been now. I've lost track of time.
Yeah, hopefully we're nearing the end. Fingers crossed.
Yeah, you guys have been in a hotbed there for sure. So no, appreciate all you guys do. Anyways, I think I'll end it at that.